Good morning. I'm H.S. Kim from SNU Hospital. First operator is Dr. Han Mo-yang and Assistant Dr. Do-yeon Hwang and Young-gu Lee and many other staffs. Let us introduce our left main bifurcation patients. Dr. Yang, please.
Okay, next slide, please. Okay, let me introduce our today's case. 65-year-old woman was presented to our outside hospital with exogenous chest pain. So she was admitted and underwent coronary angiography, which suggests a lesion at RCOs and possible left main bifurcation lesion. However, the coronary arteries in the images were very overlapped, so making the interpretation very difficult. Okay, next slide, please. Her risk factor is dyslipidemia, and the CBC and renal function tests were within normal limits. Next slide. Her current medication include DAPT and statin. And next slide. Both chest X-ray and ECG were unremarkable. Next slide, please. Echocardiography shows preserved ejection fraction with no regional world motion abnormality. And next slide, please. So this angiogram were taken at the outside hospital. So in the middle panel, you can see some stenotic lesion in distal left main. And on the right panel, it's some vague, but we can see some stenotic lesion in LAD ostium. Okay, next slide, please. In the case of right coronary artery, there is no significant stenosis, but the final stage of diagnostic angiogram, on the right panel, you can see some severe stenosis at LCA ostium. Okay, next slide, please. So at our hospital, we took the coronary angiogram again. So in the middle panel, you can appreciate the intermediate lesion from left main os to the left main body, and focal 80% stenosis at LAD ostium and 50% stenosis in circumflex os. And on the right panel, you can see some stenotic lesion, LCA ostium. Okay, next slide, please. So we performed the IVUS in the right coronary artery. You can see a pullback image from right proximal RCA. Okay, at location D, corresponding to RCA ostium, the MLA was 4.0 square millimeter with a plaque burden of more than 6%. Next slide, please. Using this angiogram, we measured angio-based FFR called μFR. So the calculated μFR value per RCA was 0.73. Okay, next slide, please. Today, we measured a true FFR. So the invasive FFR value was 0.73. Okay, next slide, please. This is a slide of IVUS finding in the left coronary artery. So you can see the pullback image from proximal LAD. The left main os. Okay, you can see LAD os lesion. So the location D, LAD ostium, MLA was 4.5 square millimeter with approximately plaque burden 50%. And when we performed the coronary angiography, so repeated damping of the fresh wave were observed. Okay, next slide, please. So this slide focuses on the left circumflex. So pullback image. So location C, left circumflex, the MLA was 3.6 square millimeter with a plaque burden 50%. Okay, next slide, please. So we also measured the MFR value for each vessel. The LAD MFR 0.63 and circumflex 0.88 and RAMS intermediates 0.85. Okay, next slide. So we also measured FFR per LAD. Yes, so the value was 0.58. Okay, next slide, please.
Okay, we prepared two discussion points for this case. The first issue is left main bifurcation PCI strategy. We consider three. The first option is upfront two stent strategy. Second, provisional strategy, one stent plus or minus balloon with simple balloon versus drug-coating balloon. The third strategy is no stent strategy, DCB only for both branches. The second issue is angiography-derived FFR, mu-FR today, plus. The first is stenting strategy. We adopt stenting strategy for true bifurcation with side branch more than 2.5 with significant territory. Plus, if there is complex true bifurcation, we do upfront two stent strategy. Crush, culotte, destenting. Plus, if it is simple true bifurcation, we adopt provisional one stent strategy with or without side branch ballooning, with simple balloon versus drug-coating balloon. If side branch TME flow is compromised, there is severe dissection or persistent narrowing, such as 90%, then we have to do crossover to two-stent strategy. Plus, the third option is no stenting strategy for left main bifurcation PCI. There is a small Korean study, as shown here. They randomized left main bifurcation patients to DCB-based treatment and DS treatment. And DS treatment all received DS, while DCB group received DS in about 25%. Crossover rate is about 25%. 1 year MACE and TLR is very similar. Numerically a little bit higher with DCB strategy, but not so significant difference. Thus, we can consider no stenting strategy depending on the lesion complexity. Plus, second issue is angiography-derived FFR, mu-FR today. On the left side, you can see timeline of the evolution of non-invasive coronary physiology. From FFR CT 11, VFR, vascular FFR 13, quantitative flow reserve 16, FFR angio 16, CAS VFFR, cardiovascular analysis system, cardiovascular angiography analysis system, CAAS. And then 19, coronary angio FFR. Finally, mu-FR was developed. Different from the previous measures, mu-FR just require one projection angle. Thus, it is possible to measure the side branch procedure simultaneously with main vessel physiology, but accumulate data limited. Plus, thus our plan for these patients is we just treat provisional strategy, one stent plus balloon. First, we would like to stent and pot with stent balloon, considering J of RI, and evaluate circuit and RI, and consider additional side branch intervention. We apply mu-FR. PRN, we would like to compare it with invasive FFR. Okay. We take several angiography, so please raise the angiography image. Okay. This is RCA graph, angiography. We notice RCA austere stenosis plus. Here's left system, diffuse left main disease, very critical stenosis is LAD ostium, mild stenosis at the ostium of Cirque and ramus intermedius, a trifurcation lesion plus. Cranial view, we can see the critical stenosis at LAD ostium plus.
Yeah, the
Okay,
final.
no.
Yeah.
Okay, please continue discussion while we are doing our procedure.
Yeah, balloon.
So he already decided his plan to treat this case, but we can discuss, I think. For this negative remodeled left main and true lesion in the proximal area of the ostium and moderate stenosis in LCX. So, any suggestion or comment
별론 준비가 안 됐나?
from the panel?
그냥 주세요.
아까 슬라이드에 LAD 그것 좀 보여줄까? 라이브 딴 거.
Well, I think this angio-based FFR sometimes is not so accurate if you cannot have a good injection. So in both left main and RCA, these are two osteolesions. So obviously the injection is not going to be optimal. But Professor Kim had used the invasive FFR wire to confirm the significance of both of these lesions. So I think this is an interesting case to observe. I think the question on this case is that how do you put your stent precisely to cover the ostium of both RCA and the left main? So I think
자, 물론
this is a
다시
technical challenging situation. You have to put your stent exactly at the ostium without
Angio-
protrusion, without too much deep insertion, so that you can cover the real ostium.
패스.
So I'd like to ask our moderator's method of putting a stent precisely at the ostium.
테스트.
Real-time IVUS guide, Zabo technique, or anything else.
For me, I
Okay,
just
no?
use another guide wire to as a marker for the ostium
In the aorta.
in the aorta, and
얼마까지 올라가는 거?
my plan is just 1 millimeter
노미너.
protrusion from the ostium.
14.
오케이.
Just making a stand position is not easy, so you should allow a little bit of the protrusion to protect the plaque.
Yes, and additional, I completely agree. And additionally,
Okay.
my strategy to RCA ostium is I select a little bit longer DS because sometimes short stent is positioning is very difficult and sometimes migrated into to the aorta to avoid such a situation. A little bit longer is better. And stent selection is I prefer very strong scaffolding stent is better because this RCA ostium is very high risk of stenosis, even drug reducing stent.
Maybe something like a Megatron.
Yeah.
Well, anyone is using a Zabo technique. I personally, I like to use Zabo, and I find it very reliable.
Will you explain the Zabo technique?
Well, basically, you inflate the first strut of the stent
왜?
outside of the
뚫지
patient,
않아.
and then you insert a wire through that first strut, crimp the stent back on.
Oh, okay.
Then, when you are inside, the inserting wire will be in the sinus
Okay.
and serve as a stop. So that when you push the stent will never go inside. But you can maintain
호스를
to
잘
cover
봐야
the ostium in a very confident and reliable
뒤까지
position.
나와 있을 테니까.
I agree Zabo technique because it can give me confidence to make sure the stand position not too deep and not just as the outside distance I have decided maybe one strut, two strut.
That makes sense
테스트.
using that technique.
많이
For
빼야 돼.
the negative
양쪽 다
remodeled left main, is
좀
there any
바꿔보진 거를
panelists
아니잖아.
have experience using DCB? Or the effect of DCB for negative
Okay.
remodeled
테스트.
lesion?
So, in the
오케이, 테스트.
except left main,
No, exactly. The main. Okay.
한번 시내하면 볼까요?
So you use DCB for negative remodeled LAD or LCX?
Yes.
I see.
Less than 3.0
Uh-huh.
millimeter.
Judgment DCB or DS is depend on the result of pre-dilatation. Response is very good. One option is of course DCB. However, dissection or something recoil DS is necessary, I think.
What about the
되게
Japanese
사까.
experience of DCA plus DCB,
Yes,
especially
yeah.
lady osteum?
That is my side field, and so optimal DCA is possible. Long-term data is very, very excellent.
슛
However, this case is,
저장하고.
of course, in Korea, DCA is not available, and this case is calcium is detected. So I'm not sure this case is optimal
16
DCA
positive?
is possible or not.
So
If
even-
calcium free, this case is a very good
Inflation?
indication for DCA, and maybe possible treat subsequent DCB treatment is possible, and the long term is very good.
So even the negative remodeled case, you use the DCA.
Negative remodeling cases, plaque burden is not so heavy, so maybe
16,
depend.
18.
Sometimes during DCA,
저장하고.
vessel sizes expand gradually. Such a situation, DCA is possible.
18이 맥시멈입니까? 20.
So HS Kim, do you do
Yeah.
the pre-dilation or just put a
We
stent?
did pre-dilation with 2.5 balloon, and we implanted Zion's stent 275 by 23, and we withdraw the stent balloon and perform a pod only to left main with 20 atmosphere, the highest pressure that permit in this balloon.
So
And
the
balloon size would be 3.5 with 20 atmosphere.
separation 되게.
so you use a stent balloon for high pressure.
Yeah, stent balloon.
Is there any concern about the stent shortening or stent elongation? The high pressure balloon
No.
with
Angle.
a non-compliant
Angle.
balloon, a compliant balloon.
Okay.
We don't have any concern. We have to save the cost.
슛.
Okay, I have one question.
Okay.
Stent proximal edge is protruded to left main,
Minus.
aorta.
We are not
Minus-
sure because no.
Here is
I
the
see.
minus.
It's hard to say.
Here's the angio. This is the location that
this
we
is-
implanted.
Okay.
Upper side and the bottom side is very
Yeah, upper
difficult
side
to adjust.
adjustment is
Okay,
important.
you have tried just.
So this is a
Enter.
science stand, is it?
Yeah,
Right,
science.
right.
Okay, so the stand edge is right on the balloon marker.
Plus. Slowly inflated the balloon.
What is the
Stent
stent
balloon.
size? 30?
Yeah, 2.75.
275.
275, 23,
Of course,
with
later.
18 atmosphere at this segment, plus, and withdraw the stent balloon only to left main for pod. I increased 10 atmosphere. The balloon size would be 3.5. As you know, the stent structure is the same, 275 and 30 Zions.
Dr.
Plus-
Kim, Dr. Kim.
Yeah.
Uh,
Yes.
Part of the balloon is still inside the guide in this inflation. Is that on purpose or is that one of your
Yeah.
trick?
It is very, Dr. Kao, you're very keen. Yeah, that's my favorite arrangement. With
Okay.
this inflation, we can expand more outside of catheter. Plus. Then this is the first angio after stent. There is some pinch of circ os. The flow to ramus intermedius is maintained. Is there any other good angle to separate three branches?
카다르다 가야 돼.
Caudal? More
Maybe.
caudal?
Maybe LAO caudal.
LAO caudal? 스파이더 뷰 한번 가볼까?
Okay.
Okay, take a picture.
Yeah.
Then we are going to measure FFR. 여기서 조금 더 넣어가지고 VFR 측정해야 되는 거 아니야?
아니, 괜찮습니다.
엔조 지금 너무 블러링 돼서. Okay.
테스트.
Next, functional
아니야.
evaluation of circumference. This can be-
완전 인게이지 안 됐어.
예.
거기서.
If FFR is okay, no additional treatment.
Yeah. 찍어보자.
예.
VFR
예.
빨리 해야 돼.
예.
이거야.
네. Sure.
Can you measure VFR with
Yeah, we
this
are doing-
angel?
Yeah.
Okay, please go ahead. While we are measuring invasive FFR, we are going to measure FFR circ, and then possible ramus intermedius, and compare the VFR digit.
Okay, go ahead. So for measuring the UFR, the
Introduce-
overlap of
introduce,
that contrast is no problem.
Yeah, the specialists say there is no problem. This is correct.
And you have to acquire the image at 15 frames per second, right?
How much is the frame rate for VFR? 15 frames
Yeah, 1
per
frame. Yeah.
second.
Yeah, yeah. Usually we use 50.
1 frame. Because for most of the CTO operator, we only do 7.5. So remember, if you want to do mu-FR, you have to change back to the 50 for a reliable calculation.
들어가야지 끝까지.
이퀄라이제이션. 네, 이퀄라이제이션. NG.
Equalization.
네.
NG.
NG please.
물로 채울까?
물로 채우시면 됩니다. 물로 이게 물입니다. 물로 채워주십시오. 네. 네, 이퀄 해주세요. 이퀄.
저
네.
아데노신 투여 시작하세요.
아직 이퀄라이제이션. 네. 아저씨 잠시만요.
관계 없지. 이퀄리제이션은 어차피 아웃티 프레셔 하는 건데.
네, 오프 해주시고
자, 너 아데노신
어드밴스 해주세요.
끝까지 쭉 내려갑니다. 그리고 Y 빼버리고.
레스팅 체크할까요?
필요 없어.
이거 빼겠습니다.
이거 아니야?
I have some discussion about the LED ostium lesion. There was a large plaque burden on IBC imaging. So Dr. Kim did stenting and stent balloon part. But if I were the operator of this lesion, I would stent optimization with a non-compliant balloon for LED ostium. So what do you think about it?
Yeah, that's the ordinary practice. Textbook-wise practice.
Okay.
Yeah. No, I agree with
What I'd
you.
like to demonstrate is textbook writes that, yeah, we have to change the balloon and use NC balloon to do optimize POT part. But actually, it is possible to do some kind of part with use the stent balloon. So I'd like to demonstrate such kind of case.
So the mu FFR is 0.67. And what is the invasive FFR?
BFR 나왔나 벌써? 어디 나왔노? 우리가
on the
모르는
screen.
가르쳐줘야 될까 이거. 참, 어디 있노? BFR이.
오프하세요.
Okay, so when we measure left main bifurcation using
강의장
MUFR,
슬라이드 왜
so
우리가 안 보이냐?
there is some limitation of MUFR program because the circumflex artery becomes a side branch. In those cases, the path length becomes shortened. So in those cases, the estimation become overestimated. Yeah, so I think after
What's MUFR
testing,
teacher?
there is no definite
MUFR number가
criteria, but so
6층입니다.
let us measure.
어디 있어?
오른쪽 위에.
So could you show us FFR value?
NGO에 오른쪽 위에.
여기?
Please show us the real FFR,
근데 왜 우리는 안 나와?
Yeah.
저 화면에
Invasive FFR value? Yeah.
not mute FFR.
Yeah, okay.
So invasive FFR number
85.
85.
Yes.
Okay.
Yeah, so invasive FFR value is 0.85.
Yeah.
한번 보자. FFR 한번 보여주지. 카메라.
카메라 넘겨줄 수 있나요?
FFR 비춰주라고 카메라.
근데 화면이 저쪽에 안 나오고 있어요.
아 지금 오케이. 우리가 안 보이잖아.
그 카메라
우리가
앵글이 안
보여주게
맞아요.
해줘야지.
아니.
No.
얼마 더 나왔노 그래서?
요거 카메라 조정해야 돼요.
0.85.
0.83.
83.
Yes, yeah. 0.83.
Invasive FFR 83. And the MUFR 얼마? 60.
67.
67. Huge difference. So MUFR is not totally reliable. Of course.
But we said the left circumflex has the main branch. Maybe the value could be changed. Yeah, so could you do that?
Okay, just pull back. Invasive FF pull back. While meet 10.
라이브로 바꿔주세요. 레코딩 해주세요.
I'm going to pull
Now
back.
Can we see the
85,
pressure?
86. Then we are going to pull back the invasive FFR pressure wire. Now 85.
We can see
85.
the only aorta pressure.
86.
Mm.
85. 90. 95.
We need a
96.
FFR screen.
99.
Hyo-Soo.
100. Yeah.
자, 요거
It is impossible to transmit the FFR.
카메라 좀
Thus,
보여주세요.
I just convey. So it start 83 reach 100. So in this FFR measurement was correct.
여기다
The
보여줘요.
MUFR was 얼마? 60.
67이었어요.
0.68.
So
MUFR 밸류가 있냐고 지금.
in this particular case, mu FFR post stenting overestimate the severity significantly.
Yeah. Okay, then we are taking another angiography to reassess the mu FFR for circ. 저 아까 다이 플로우 되지 않게끔 잘해가지고 한번 찍어보지.
Okay, test please.
This view 괜찮을까? 다시 세잖아. 인게이지를 해야 돼. 제대로.
How about taking the spider view to obtain the straightening LCX coronary angiogram?
Okay, yeah. Your success
보자.
is very good.
보자.
Yeah, the foreshortening and the overall.
테스트할게.
Okay, test.
지금 좀 덜. Okay, just we are going to take two MUFR on the arteriocaudal view and iliacaudal view. Okay,
Okay.
Snap,
Yes.
준비.
Yeah. Snap, please. Okay.
스파이더 뷰. 저 이미지 가서 VFR 계산해보고. 좋네요, 그죠? 살짝 테스트 해볼게. 괜찮나?
Okay. Yeah.
오케이.
Snap,
Ready?
please.
Okay, we are going to calculate two VFR, on the aerial caudal view and the aerial caudal view. In any way, invasive FFR told us that there is no significant perfusion disturbance to circ. I think Ramus intermedius is good. Because I'm going to Ramus intermedius
Yeah.
average.
So we got another value using VFR. Yes, as I mentioned before, we set the left circumflex as the main branch. The value, VFR value was 0.8.
VFR was 80, FFR was 86. Closer. Okay, 자 빼버리고 라이트로 넘어가지.
Yes.
So will you check the IBUS for LAD?
No,
We already pulled the wire.
we are going to move on to RCA.
Okay, go ahead.
Aren't you
Meanwhile,
going to
we are-
check the left main osteo by IVUS?
And additionally,
Okay,
I think
해줄까? Okay, if you want.
2.75 ballooning is a little bit small for left main standing. So
테르모.
I think I recommend more bigger size pot strategy. And after that, sometimes Carolina shift is sometimes induce more severe situation, and if necessary, additional function studies may be necessary, I think. Anyway, a pot is necessary.
Hyo-Soo Kim, panelists don't want to see IBUS.
바로 해줘야지.
They are doubt for the result of the left main.
Yes, that is very important.
자.
저 인트로더스 어딨지?
플라식 좀 해야지. 플라식.
런스를 주고
But for the RCA, Hyo-Soo,
Okay.
the IBUS, the result is not the interventional lesion. Isn't it true?
RCA was significant.
But the lumen area is
FFR was
more than 4 square millimeter.
FFR was about 70.
Yeah. 0.76.
0.76?
Yes.
Yeah, 76.
True FFR?
Yeah, in this FFR.
Epicranial.
테스트 할까? 오케이, 늘어.
Okay. IBUS, please.
Because from the previous Korean study, we
flushing.
understand that treating left main, you must finish with the IVUS, or because otherwise there will be a lot of unrecognized stent deformation or problems or issues, right? And that is associated with the high
IVUS on.
event rate.
오케이. 약간 앞들고. 자, 풀백 스타트. Can you see?
Yes.
IBUS, please.
해줘야지.
But guiding catheter position should be more out. Huh?
Yes. Yeah.
Yeah, we retrieve.
Oh, okay.
With a lady, distal edge is good. MLD is about 3, 2.75.
LCX source.
보자. Left main.
Left main.
Okay, left main. 275. Okay, ostium.
Okay.
We play again.
I think that's optimal protrusion. Huh?
Position is okay, and
Yeah, very good.
so longitudinal positioning is okay. However, left main in the room is, I'm not sure, and this is acceptable or not. Maybe more bigger put additional strategy is better.
So Igarashi sensei, what's the number in your mind?
Yes, at least usually I finish 3.5. But
I mean area.
Area left main is if possible 7 or 8 millimeter square is best.
다시 LAD OS. The unexpanded portion most severe at the LAD ostium.
Yes.
That's
But
the lesion
if we
with a
inflate
large
further
plaque.
LAD ostium, there is a carotid movement toward the RI and circ. That is my compromise. Anyway, we can do additional ballooning with NC, but 3.5 is too aggressive because vessel size is about 3 or 3.25, but actual luminal diameter was about 1.5. That's we initially tried to implant 3.0 stent, but Dr. Young's opinion was it is too big. Thus he decided to implant 2.75. But we can do post ballooning with 3.0 NC, but we have to accept carina shift further toward the RI and the circ. Okay, 3.0 NC balloon. Well, let us examine the after NC with high pressure balloon, LAD ostium and left main, how much the circ impingement happen. Do we have enough time for such kind of experiment?
We can see the final result of the high pressure NC balloon. Then
Okay.
we're gonna move to
3.0,
severance.
12, 3.0, 12, 15.
15.
프레셔는 어떻게 되죠?
Pressure is nearly
노미널 프레셔 얼마지? 12. 하이스트 프레셔는
아래 코더. 아래 코더.
아레오카보다 테스팅
So Dr. Kao, as you mentioned, the IVUS
조금 더.
is very important for the left main intervention.
We are going to touch cover LAD ostium. 얼마 노미널 얼마?
12입니다.
12 atmosphere. 이래 나오지 않았어? 괜찮나? 테스트? 오케이. 테스트 해보자. 어딘지.
테스트. 충분히
네. 자, left main. 너무 놓은 것 같은 테스트 해볼까?
3.0 is relatively small for left main. You need the bigger size, like some 3.5.
얼마? 20, 얼마?
22.
22, 30 NC balloon. Yeah, in common sense, 30 for left main is small. But Dr. Yang think the vessel is not so big. Okay. 준비를 넣어요. 가이딩을. 그래야 very
But
easy.
this region is a negative limodal to left main. According to the size of proximal LAD, is the plaque, including plaque, the vessel size is around 40.
아, 이렇게 된다니까. Okay, we are going to do IVUS once again. 아까 데이터가 나와 있으면 한번 비교해 보죠. 얼마나 좋아졌는지.
네. 아, 알겠어.
너무 나왔다. 안 들어가겠다.
Okay.
오케이. 저 IVUS로 트랜스미션 화면 전환. 오케이. With the lady,
Yes, we can see the
this landing
IVUS.
zone is good. MLD is about 275. Good opposition. Proximal LAD. 볼까? Yeah, LAD ostium. MLD is 3 by 2.5. This left main 275. Three. Do you feel any significant change
Little
before
bit.
and after NC ballooning?
It's much better.
Much better? Okay. Compare the digit. 아까 LAD ostium하고 this left main 한번 보면은
NG.
here is the LAD ostium. MLA was
Almost
5 square millimeters. How was previous digit?
4.74.
Previously 4.8. Now improve it 5.1. 0.3 improved. Okay, this left main.
0.3 square millimeter.
Now 6.8 square millimeters. How was previous digit? 아까 측정해 놓은 거 없었나?
Yes.
이거 previous one. Previous one is 5.5. 5.6. First 6.8.
Yes.
Very good.
1.2 difference with 30 NC balloon with 22 atmosphere.
Very good.
Okay, can you see the pinch of circumflex ostium?
Yeah. Snap, please.
말고 또 engage 잘 안 돼.
Yeah.
아니 찍어보자고.
Yeah. Yeah.
테스트.
Should.
Luckily, circumflex ostium a little bit worse, but it may be okay.
Looking good.
But if time permits, we are going to repeat invasive FFR for circ. Is it okay or not? FFR?
FFR wire.
아, 준비를 안 했나? The trade-off is a pinch of side branch after a high pressure inflation of main vessel. But this finding, I think, acceptable. But circ territory is wide. 어이구.
So you are going to remeasure the LCX FFR?
Yeah. Our team are doing every effort to show you as much information as possible. 됐어?
인troduce.
잘 잡아라.
인troduce.
꼭 잘 잡아야 돼.
Can you do mu FFR again in this view?
Okay. Yeah.
뮤에프랑
Could you do the BFF with this image?
니는 집중만 해. 내가 알아서 할 테니까. 요거 가지고 뮤에프를 측정해.
해서 두 개 3D랑 2D 다 해놓을까? 아니 마지막 이거 한 번 더.
So now, how many hospitals use this kind of UFR or QFR in Taiwan? How is the?
Yeah, we do have MUFR in our CAT lab, and actually we have done a small comparison study to compare the invasive versus angio-based. The accuracy is overall quite good. Of course, there are some discrepancy, but in low percentage. But like I said, you have to remember to go for 15 frames per minute per second.
Okay.
Otherwise, you cannot read. You cannot get the MUFR data.
How's it in Japan?
So we can use mu
Equalization.
however, only diagnostic.
Diagnostic.
Simultaneous usage for the mu and PCI is not covered by insurance.
Oh, I see. For the diagnostic UFR is covered by insurance?
Yes.
Oh.
So you actually get an extra pay with the MUFR.
Oh yes.
In Taiwan, it's complimentary. I mean, free of charge.
Equalization. Once again. Okay. Okay.
Okay.
도리.
Okay.
Okay. 아데노신.
주세요.
자, 요거를
화면을 좀
카메라 비춰가지고 보여주면 될 것 같은데, 야, 당긴다. 조심해라.
이 카메라.
FFR screen?
Yeah, I prepared.
화면 좀 바꿔달라
the screen.
했어요.
Okay.
You can see.
Mm-hmm.
Okay. So we just started
this is-
infusion of adenosine through IV. Okay.
Yes.
So now
Recording.
TGD is 96 for this circ.
Sorry.
뭐가 소리야?
The FFR wire.
와이가 좀 빠졌습니다.
.88.
일단 오프하세요. 됐어. 그대로 놔둬. 레코딩.
How about this?
87. 그전 디지트는 얼마였지?
지난번 8.
Previous digit was 85 circ. The angle between left main LAD and circ is a little bit obtuse. Thus, even though we did a post ballooning through left main to LAD ostium, The impact on circ flow is minimal.
Okay.
86, previous digit.
Thank you very much for your effort. And UFR is so somebody can manipulate the number.
UFR
Yeah, how
나왔으면
about UFR level?
UFR digit 나왔으면 이야기를 해줘. 은밀하게 저쪽으로 넘기지 말고 우리가 모르는 사이에.
Yeah, I'm going to pull back the pressure wire.
Somebody
Yeah,
shows
pull back
that the
pressure wire.
UFR number can change from 0.57 to 0.88.
UFR은 88 나왔습니다.
그 전에 얼마였지?
It is very operator dependent.
Okay, Hyo-Soo Kim, thank you very much for your effort. We're gonna move to the Severance Hospital.
Yeah, UFR changed a little bit from 80 to 86, improved.
Okay, thank you for your nice job. Thank you very much.